Good day, evening, everyone. Welcome to our webinar. My name is Hiba Jabarti from the Saudi Patient Safety Center. Today, you are with us in this webinar that's presented in collaboration with the Saudi Patient Safety Center, the National Authority for Patient Safety in Saudi Arabia. The Saudi Patient Safety Center's mission is to promote a culture of safety, reduce the preventable harm, and ensure safer healthcare through education, innovation, and evidence-based policies. You will be hearing a presentation from Dr. Faisal Khtami, Dr. Asya Rogan, and Ms. Najah Siddiqui. They will be speaking to us on caring for tomorrow, rare cases of preventing newborn harm. Dr. Kithami is a consultant OB/GYN, specialized in women's health, head of quality, monitoring and improvement department at King Abdullah Medical City. She chaired a maternal mortality task force and many root cause analysis, holding a master's degree in bioethics. Also, you will be hearing from our speaker, Dr. Asya Rogan. She graduated from King Abdulaziz University in Jeddah and holds a membership of Royal College Physicians from England, graduated of Saudi Board of Internal Medicine. She had a Saudi Adult Critical Care Fellowship. Also, she holds a fellow from University of London, Ontario in Canada, master's degree in healthcare services and hospital administration from King Abdullah University. She was a previous program director for Saudi Board of Adult Critical Care Residency Program in the Wizards region. Currently, she is the Director of Critical Care Services at King Abdullah Medical City and Critical Care Lead in Mecca's cluster. Our last speaker, she is Ms. Najah Siddiqui. She is a patient safety specialist at King Faisal Specialist Hospital and Research Center in Medina, with over 21 years of experience in nursing, quality management, and clinical risk management. She has led various hospital-wide safety initiatives, including the implementation of patient safety towards excellence framework, high reliability organization program, and national collaborations with the Saudi Patient Safety Center. As a certified healthcare quality professional, she is dedicated to fostering a culture of zero harm and enhancing patients' outcome. Dear participants, now moving along with to our session, please welcome Dr. Faisal Kami. Just I want to highlight before I shift the mic to Dr. Faiza that the questions will be at the end of the webinar. Kindly post it in the Q&A icon. Dr. Faiza, the mic is yours.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين. Good evening, everyone. Today, we gather not just to talk about patient safety, but to confront the silent tragedies that happen in delivery rooms, clinics, home, and across our community. Behind every statistic is a name. Maternal safety is not a luxury, it's a test of our humanity. My name is Faisal Githami. I will share with you today the outcome or a nutshell and a sneaky peek of the outcome of the maternal mortality task force that was conducted in Makkah Health Cluster in order to investigate 46 maternal deaths across the Makkah cluster. And I will share with you one of the important finding. But before that, I'd like to start with the exploring the philosophical landscape of medicine. إحدى أهم أصول الشريعة وإحدى أهم القواعد الفقهية قاعدة لا ضرر ولا ضرار، وتعتمد عليها كثير من الأحكام الفقهية في الطب. First, do no harm. This is the Hippocratic Oath. It extends beyond treatment and it demands systemic prevention. I am because we are. This is a mother's safety. A mother's safety is a reflection of our collective humanity. The butterfly effect in healthcare mentioned that small systemic failure in prenatal care can lead to catastrophic outcome. That's why prevention must start early. One of the important observation from Maternal Mortality Task Force that 100% of women they did not have antenatal follow-up, and that was the neglect before tragedy. 30% were illegal resident, and that happened when fear of deportation outweighs fear of death. Missing psychosocial assessment, and it happened because we treated bodies, not mind, and we lost both. The three important causes of maternal death were cardiovascular, preeclampsia, postpartum hemorrhage. Cardiovascular disease account for 18% when hearts that stopped beating because no one listened. Preeclampsia, 17% of the cases, which is a preventable storm that we saw coming, but we didn't shield against it. Postpartum hemorrhage accounts for 26%, and this bleeding out is in the land of medical miracles. These numbers are not just data points. They are unfinished lullabies, empty cradles, and silent slaughter. The question is not why did they die, but why did we let them? The 100% lack of antenatal follow-up in our cases is not a coincidence. It is the root cause that allowed all other causes to flourish. It was the missing shield that would have deflected the fatal blows of preeclampsia, hemorrhage, and heart disease. The root causes, the main root cause is lack of antenatal care, and I consider it the most and the last root causes. What is the definition of lack of antenatal care? It refers to the situation where a pregnant woman does not receive the recommended number and quality of healthcare checkup and services during pregnancy. Antenatal care is not fundal height and listening to the fetal heart. Antenatal care is one of the most critical factors in preventing pregnancy and childbirth complication. Why? Because it allows healthcare providers to closely monitor the health of the mother and the growth and the development of the baby. It also helps in the early detection and management of potential problems such as preeclampsia, gestational diabetes, infection, fetal growth retardation. It also provides intervention to prevent issues like anemia, and also it emphasizes immunization. It is a key opportunity to educate expectant parents about pregnancy, nutrition, labor, delivery, breastfeeding, and newborn. It also provides a space to screen for and address mental health concerns like antenatal depression and anxiety. It also helps in building trust and relationship between pregnant women and healthcare provider and making it easier to ask questions and voice concern. To ask if antenatal care is important is to ask a more fundamental question. Do we believe in a proactive or reactive model of medicine? The birth plan becomes a safety plan. It evolves from I want a water birth to based on your heart condition, we will plan your epidural early and we to reduce cardiac stress. And we will deliver you in main OR with cardiologist team on board. And we will monitor you for the first 48-hour postpartum. This is a safety plan. This is a birth plan. So what can we do? We should enhance access and equity. by establishing satellite antenatal clinic, implement integrated care model, develop first appointment guarantee program that ensure every pregnant woman has an initial appointment within 14 days of a positive test, target outreach program for high-risk group, illegal resident, low-income families through community leaders and outreach work. Also, empower patient and community through development of pregnancy pathway digital platform, launch group prenatal care and supportive care, create multilingual health literature educational material, implement universal screening for psychosocial need, improve quality and standardization through adoption of unified antenatal protocol, launch monthly interdisciplinary and meeting and grand round and case review, implement standardized competency training, establish perinatal quality collaborative. In conclusion, antenatal care is the foundational pillar of patient safety from the start. The best way to save life is to never let it be in danger in the first place. Investing in universal, accessible, and compassionate antenatal care is not just good medicine, it's a moral obligation to every mother and every child we have sworn to protect. In the end, patient safety is not a protocol, it's a promise. It's a promise that every mother who enters a hospital will leave with her child in her arms, not her name on a maternal report, mortality report. The measure of a society is not how it treats its most powerful, but how it protects its most vulnerable. Let's be the generation that made safe from the start, not just a slogan, but a reality. Thank you.
Thank you, Dr. Faiza. Now we will move to Dr. Asia. Dr. Asia, the mic is yours.
Assalamu alaikum. In this part, we'll discuss life-threatening management for obstetric emergencies. So the objective of this lecture is going to be to identify leading causes of maternal mortality, as discussed previously by Dr. Al-Githami. Discuss life-threatening case scenarios. We'll go through 2 case scenarios that's really, we think, interesting, and it save life-threatening situations with obstetric emergencies, to learn emergency management strategy and to discuss preventions at all care level, and to highlight the role of healthcare system and teamwork in the management of life-threatening situations in obstetric critical care. The global burden is known. It's been reported by WHO that more than 200,000 maternal deaths was reported in 2020. 94% of them happened in low resource settings, and most of the deaths are preventable. The major causes of maternal mortality, it's been mentioned in the previous lecture. So it's very much limited, as we see here. And it's, I think, known to even graduate from medical school. So it's limited to hemorrhage, hypertensive disorders, sepsis, unsafe abortion, and obstructed labor. And that would make a big safety margin for clinicians to act very fast whenever they come across cases of life-threatening obstetric emergency. Again, life-threatening emergencies were narrowed within the previous causes that I mentioned previous slide as a common causes for mortality. So going through the first case, we have a 28-year-old patient who was unbooked at 32-week gestation at presentation. Presented to ER with convulsion, was diagnosed as an eclampsia, and with that, as a consequence, she developed aspiration pneumonitis, which causes a severe ARDS situation. Her vital sign revealed a pulse of 120, respiratory rate was 45, so she was quite tachypneic. Blood pressure was controlled, at a margin on magnesium sulfate infusion, and she was having an oxygen saturation of 84% on non-breathing face mask. So the ICU were consulted because of her severe respiratory distress and severe hypoxemic respiratory failure. And once the ICU arrived, the case was intubated, connected to a mechanical ventilator. And with that, she required a high ventilatory support with peak of 16, FiO2 was 100%. And despite that, her oxygen saturation was barely in the 80. The obstetrician was at the bedside pushing for pregnancy termination with a cesarean section just to save a baby life. And we understand once mother become critical with this severe hypoxia, the concern goes that we may go into an emergency cesarean section. However, with the presence of intensivist, we hold the decision because transferring patient to the OR with that severe hypoxemia would be a life-threatening and might end up with a maternal death on the route, which would definitely affect also the baby. So a multidisciplinary meeting was called for, and the case was reviewed with the engagement of the family. And the decision was taken that the case has to go for VV ECMO. ECMO was immediately consulted, and luckily we have King Abdullah Medical City near the hospital, the MCH hospital, where immediately ECMO was inserted, achieved oxygen saturation of 100%. And the case became safe for transport to the OR, as well as it was a salvage for mother life also. A cesarean section was performed with the patient with an ECMO. Then the case was transferred to a tertiary center, King Abdullah Medical City, immediately after cesarean section. And we see that with the outcome, where mother was weaned off ECMO within 5 days, she showed an excellent outcome, extubated in the 6th day, and within 1 week was shifted to the floor. The baby required neonatal ICU for 4 weeks and discharged afterwards stable. The takeaway message from that, ECMO buys time and allow coordinated care. So a second scenario is much more easier than the previous one. That scenario would reflect an integrated, coordinated, and high-level care. A second scenario would go through it. A 36-year-old booked female patient was coming from Al Qanfuta, pregnant in 34 weeks, was having a COVID with chest infection with respiratory failure, and would say a moderate ARDS. Her vital sign revealed a normal blood pressure and temperature. She was tachypneic with a rate of 40, and she was a little tachycardiac. Oxygen saturation was 85 on room air. For that, she was connected to oxygen. And the chest X-ray revealed bilateral aerospace disease, suggestive of moderate ARDS. Her hemoglobin, upon review of the lab result, was 8. The ICU was consulted, and the patients would put on high-flow nasal cannula, and oxygen saturation improved to 94. The respiratory rate was down to 30. A previous visit so once we reviewed the case with that hemoglobin, we asked for a baseline hemoglobin, and it revealed that in a previous visit to the hospital 10 days ago, revealed blood transfusion, that she received a blood transfusion and discharged with a hemoglobin of 10. For that, and knowing her background from Confuda, we requested for hemoglobin electrophoresis, which revealed hemoglobin SC diagnosis. So a multidisciplinary team was conducted with the family, and the diagnosis of acute chest syndrome with COVID chest infection was there. So received blood transfusion to correct hemoglobin less than 30, and the decision was made in 24 hours to undergo epidural cesarean section on high-flow nasal cannula. The baby was alive and taken to the neuro ICU, and the patient showed a significant improvement in patient respiratory status, weaned off high-flow nasal cannula in 2 days, and discharged from ICU in the 6th day. The takeaway message: a basic review of patient basic history, enhance optimum care, and as you see, it come up with the survival of the baby and the mother. So what we did in the previous two cases is, as you see, what called emergency obstetric care system. There was an early recognition of the situation, an early response. A rapid response team was on the ground with the intensive care. A multidisciplinary team work was there for the decisions and coordinated care. Resources was available, not on the same hospital, but it was available across the whole cluster. So ECMO was salvaged for one case. And here is what emergency obstetric system. An emergency obstetric care system is part of the emergency management strategies where it indicates a capacity of the healthcare system to handle obstetric emergency at any given time and to provide timely care. It's a set of essential services and interventions that has to be available continuously, from the antenatal care with the family physician up to the advanced tertiary care. It manages life-threatening obstetric complication once it's happened at any stages. The team should compose of the community health care worker, midwives, obstetricians, specialized care providers such as intensivists, anesthesiologists, cardiologists, nephrologists, and neurologists. And it operates continuously, but it includes an immediate management of the emergencies once it happened. The goal is to provide continuous essential care and to prevent complication. Now, part of the system is the rapid response team called obstetric rapid response team. It responds quickly and effectively in acute obstetric emergencies. Should compose of obstetrician, anesthesiologist, neonatologist, midwife, nurses, intensive care, and some other trained specialized care parties. The goal is to stabilize the patient quickly and efficiently. So this is one of the basic but very important strategies to salvage maternal care during emergency. And I think it should be available in all say clusters across the whole kingdom. It's not necessary that we have the whole team members available within the same institution, but should be available within the same cluster at least. The presence of emergency obstetric care system through many of the researches conducted, it reduces postpartum bleeding-related mortality by 50%. It reduces eclampsia-related mortality by 30 to 40%. It reduces obstructed labor-related mortality by 60 to 70%, and sepsis-related maternal deaths by 50%. It reduces maternal mortality in rural and remote areas by 50 to 70%. So it's highly efficient and effective. Talking about advanced life support and ECMO maternal emergencies, this is one of the important tertiary care level life-threatening care that I think it's available across the whole clusters. It needs just a bit of integrated care. So the goal of advanced life support in obstetric emergencies is to prevent irreversible organ failure and support fetal oxygenation. When maternal emergencies that may require, what are the maternal emergencies that require advanced life support? As you know, suspected amniotic fluid embolism, postpartum cardiomyopathy, severe ARDS, massive bleeding or cardiovascular collapse, eclampsia and status epilepticus, or any hemodynamic, would say, instability or respiratory failure that does not respond to the available supportive measure. The component of advanced life support in maternal care, it includes airway management, mechanical ventilation, advanced life support, massive transfusions, intraopen hemodynamic management, continuous monitoring in ICU, ECMO support. What is ECMO? I think ECMO after COVID pandemic, it's known to all of us in the kingdom, but simply it's a machine that support the heart and the lung. It's temporary support patients with severe cardiac or respiratory failure. It's two types, simply VV ECMO to support the lung, and VA ECMO or veno-arterial ECMO to support the heart and the lung, and can be a life-saving in pregnant and postpartum patients not responding to conventional support. Indications for ECMO, as we mentioned, severe ARDS, peripartum cardiomyopathy with shock, massive pulmonary embolism with shock, amniotic fluid embolism, severe sepsis or refractory hypoxemia. Patients failed CPR, what we call ACPR or ECMO CPR. ECMO in pregnancy need a special consideration, especially that we know that with pregnancy, there is increased blood volume. So with ECMO circuit, a volume requirement might be there. So we keep in mind once we consider ECMO, a hypercoagulable state is an issue. So clotting of the circuit, we have to consider and we have to monitor and treat. Uterine compression might make difficulty during cannulation. So positioning or repositioning might be there. It needs multidisciplinary team, the presence of obstetrician, intensivist, ECMO specialist, neonatologist, and anesthesiologist. What are the outcome with ECMO in pregnancy? It is reported that maternal survival reach up to 80%, 88% in recent reports when used early. And fetal survival depend on gestational age and timing of delivery, but reported in studies survival from 69 to 89%, which is, as you look at that, these figures were done in a refractory cases. We have to remember, so it salvaged a significant number of them. The studies emphasize that the outcome depend on early initiation, center of experience, and individualized management when we consider ECMO. Challenges and limitations with ECMO, it's a high resource intervention, not widely available in all regions, require ECMO-trained ICU team, risk of bleeding, infection, thromboembolism is there. The ethical consideration of maternal versus fetal viability, because as you see, mortality, OTC survival with of maternal survival is higher than fetal viability. However, the decision should be based on multidisciplinary team and family engagement. When to refer for ECMO, sign of impending cardiorespiratory failure, persistent hypoxia or hypotension, early involvement of tertiary care center with ECMO capacity. All of us know that we're lucky that we have the national ECMO referral pathway in place who are accessible 24/7. And among the cases that received are pregnant patients. So in summary, a system-based level to reduce maternal mortality is needed. The level of prevention of maternal mortality is as equal as emergency and life-threatening treatment, because at the level of prevention, we can start earlier with proper screening, antenatal care, good nutrition, family planning, secondary level facilities, early detection of those at high risk, and basic emergency obstetric care. At tertiary level, advanced emergency care and ICU referrals shall be available. And we should have a system and policy here in the last column, where documents has to ensure emergency and transport and referral, skilled birth attendees shall be there, maternal death surveillance and response must be done, M&M review and audit, and community education. So, however, what really matters, because I'm sure everywhere we have all the setup, including the policies and procedure, but then what needed is prevent the 3 delay models, which are delay in decision to seek care, refer early to next team member, and have a multidisciplinary team care as soon as possible. Delay in reaching facility. Many of the patients who arrived to access to care, they usually have a poor outcome and mortality. Delay in receiving quality care. Again, consider all the potential and all the options when we treat obstetric emergency. And as we have seen in the scenarios that we salvage patients with that. In conclusion, maternal deaths are preventable. Emergency readiness saves lives. Training, resources, and system support are mandatory. ALS or advanced life support and ECMO are life-saving tool in severe obstetric emergency. It's not the first line, however, it's critical in specific and severe cases. ECMO require rapid identification, tertiary care availability, skilled multidisciplinary team management, and every minute in obstetric emergency really matters. This is the references I use in my presentation, and thank you.
Thank you so much, Dr. Asia, for this interesting presentation. Now, moving along to our last part of the webinar, to Ms. Naja Sadiqi. Ms. Naja, the floor is yours.
Thank you, Ms. Hiba. Okay. So good evening, everyone. Thank you for joining our webinar. Today we will focus on the newborn and child safety. I'm Najla Siddiq, patient safety specialist from King Faisal Specialist Hospital, Medina. And my session will be on newborn and child safety lessons learned. So newborns and children are among the most vulnerable patients because they cannot advocate for themselves. A small mistake can lead to a devastating outcome. By analyzing past events and near misses, we can identify system gap and design stronger safeguards that make safety easier and more reliable for staff. When we think about patient safety in pediatric, we must focus on few high-risk areas: correct patient identification, safe medication use, fall prevention, timely and accurate diagnosis, recognition of early sign of sepsis and deterioration, and effective handover between staff. Each of these are presented at a point where safety can break down in a system if the system is weak. Correct patient identification for newborn. One of the most frequent near miss in a maternity and pediatric setting is incorrect patient identification. What do you think the factor contributing for misidentification? There is many factors. One of it, fatigue, interruption, similar name, especially in Saudi Arabia or Arab region, we have a lot of people who have the same first name and middle name and family name. Time pressure, distraction, multitask, especially when we have emergency situation. So you will be in this pressure with multitask and you have to act very fast. How we can prevent such misidentification in this situation? We have a lot of tools that help us to prevent it. We have to look for barcode electronic ID bands, which will help us a lot to prevent misidentification. Double check or staff verification. And this is very important before placing the ID band on the patient or the pediatric neonate. We need to have a quiet zone during ID band, and this is very important. Some situations, especially in emergency situation, this is difficult. Parent engagement in checking the ID band, and this is very important. Education, ask the patient, the family to speak up when they feel there is something is not appropriate or incorrect. In pediatric, medication error are particularly dangerous because dosage are small and weight-based medication. And this we'll find it a lot in pediatric setting area. We've seen errors such as double dose due to slip on lapse or incorrect dilution. We know that medication for pediatric is very critical and high risk. So any medication should be double checked before administering to the pediatric. Error often occur when staff are mistaken or when a lookalike or sound-alike medication are stored together. Automated dose calculation in electronic prescribing is very essential to prevent error from happening. Separating lookalike and sound-alike medication is very important, and this is one of the requirements to prevent error and one of the international patient safety goals. Color-coded label, and this can help to identify our early to detect when it's wrong labeling or medication. Using smart pump help us to put correct dose and rate for medication. Cross-check with the patient weight is very important, and this has happened especially when we have multi-layer protecting or before administering the medication. For example, we have the system alerting us when there is wrong weight entered, or we have a pharmacist who will verify the dose and make sure that the weight is correct. And also the last safeguard is the nurse before administering the medication to double check before administering to the patient. Set up an independent double check is very important, especially for high risk medication. And when we deal with the pediatric, all medication considered as a high risk. This step greatly reduce the chance of an overdose or wrong medication. We have also seen cases where children fell from bed or crib, often when left unattended even for a few seconds. We know that pediatric or kids are very vulnerable to fall. They are trying to explore the area, so they move without feeling there is a risk of danger. Contributing factor could be poor environment design or lack of awareness. Fall occur when the environment is not adapted for children or when parents are unaware of the risk. And this is very important. Educating family from the admission is very essential and important. How we can prevent fall, especially for pediatric population? Use low-high crib with secure rails. Many families, they unintentionally, they leave the side rails down. And this is very important to remind them that we have to keep it up. Doing regular round will making sure that pediatric are safe. Bed alarms for high-risk patient. Clear signage will keep it in the room for the family to remind them about the safety. Also, on admission, some of the hospital, they will ask the family to sign a consent about understanding about the fall risk. Reminding a parent to keep the side rails up. So you can give them a pamphlet or we can give them education material, barcoding, education, just to remind them about the safety and how we can prevent injury from fall. Sometimes in the procedure, the family will insist to keep the child in their lap, and more often the fall happen at that moment. So it's very important to educate the family and ask them to reply back if they really understand about the fall risk and what will happen later. Some of the most serious cases occur when a diagnosis is delayed or when staff miss early sign of sepsis or deterioration. In several cases, indicate warning sign were present but not acted on quickly enough. So delay of or missing sepsis or deterioration can affect patient or pediatric very seriously. What we learn from this, reliance on the clinical judgment alone is risky. Early changes in children condition can be overlooked if staff are busy or inexperienced. How we can prevent it if we design the system to to alert us by pop-up alert, or for example, we have a tool to detect any warning sign that patient is having serious deterioration. So there is some tools available for early warning scoring tool, help us to calculate the risk from the vital sign. We can have also set automated alert in the electronic system for abnormal result. Implement escalation protocol that require immediate serious review. So sometimes when the primary nurse, for example, or the lab, when they call the physician and they don't respond to them or they don't act on, we have to escalate in an appropriate way according to chain of communication. Simulation training helps staff to recognize how to escalate life-threatening or changing in the real time. So this is part of the education and continuous education. So staff will be aware about the early sign. Handover is another area where safety can fail. Information can be lost between shift or when child is transferred from one department to another. When we hand over in an unstructured way, or there is interruption or critical details were missed, can cause a very severe, serious harm. How we can prevent it? Using structured handover format, for example, SBAR or IPASS. And if it's automated in the system would be better because it can capture the data. Also should be updated, highlighting the very important information, giving in the information also in the handover that what is expected plan for this patient, for example. Also consider practice build reliability. When we do handover, it should be in the quiet place, structured. The handover too should be placed in an accessible way, should include all the updated information. When we look at these cases together, a few themes emerge. Staff under workload and more prone to error. Communication breakdown allow important information to be missed. Tool and environment are sometimes designed in a way that increase the risk of mistake. Family are not always engaged as a safety partner. These patterns show us where to focus over prevention error. So action plan to prevent such error from happening. To address this risk, our first set of solution, digital identification such as barcode or RFID, which is radio frequency identification, will help to prevent misidentification. If we don't have, we can do independent double check and ensure that the ID band are correct placed for the patient. Medication safeguard, automated prescribing with a weight-based alert and smart pump. And this is very important to help us to prevent medication error. Fall prevention bundle, safe bed and crib design, visual cue, alert, and parent education. These measures are created barriers that make it very difficult for error to reach the child. Other solution on critical condition and communication, sepsis and deterioration dashboard, real-time monitoring and alert when a child risk score increase. And this is very important, and we have to combine it with the escalation process. Safe handover system, so whether we have a digital template to have it standardized and set it in the place that everyone can reach it, update information, structured information. When we do the handover, we make sure that there is no distraction, no interruption, secure time to prevent missing information, highlighting very important information and plans. Also, training and simulation is a good tool to help the staff to feel and understand the emergency practice and the scenario, and to learn to spot early warning sign. Together, these solutions strengthen our ability to detect risk early and respond quickly. In conclusion, each incident, whether a medication error or a fall or delayed diagnosis, provide valuable lesson. By learning from these cases and implementing robust system level safeguards, we move closer to a culture of zero harm. Safe care for every newborn and every child is not just our goal, it's our responsibility. As we come to the end of this session, I want to leave you with a reminder from Florence Nightingale, the founder of modern nursing. The first duty of hospital is to do no harm. These words are so true today as they were over a century ago. They remind us that safety is not optional. It's every foundation of care. For our newborn and children who cannot speak for themselves, this duty is even greater. And every band we check, every medication we verify, every handover we complete with care is a step toward honoring that promise. Our responsibility is not just to treat illness, but to protect our patient from harm. By learning from every incident, strengthening our system, and working together, we ensure that safety is emerged in every moment of care. Let us carry this principle toward our patient, because when we protect the smallest and most vulnerable among us, we protect the every heart of healthcare. Together we must deliver on this promise, safe care for every newborn and child. I will close my presentation with error are not caused by bad people, but by weak system. By strengthening our system, we protect our most vulnerable patient and ensure that safety is never left to the chance. Thank you. Okay, now we will start our open panel discussion um, with Dr. Faiza and Dr. Asia. So I will start my first question to Dr. Faiza. Your presentation highlighted that 100% of cases reviewed lack of antenatal follow-up. Why do you think this systematic failure persists, and what actual strategy can close this gap?
Okay, Bismillah ar-Rahman ar-Rahim. Thank you for this question. This is a very, very important a question and very important finding. I think our healthcare system is different a bit in a way that pregnant women they do have the mindset or the culture of being healthy, so they don't require or they don't need to be seen, especially if a woman is multiparous and she had experience, previous experience. So the mindset or the culture is that antenatal follow-up is just wasting of time. Another barrier is the lack of support sometimes from the from families, like for especially for multiparous or women who had kids. So in order to visit the hospital several times in 9 months, it's a burden. The other obstacle is a fragmented level of fragmented system. We have a governmental hospital and we have a private hospital, and we do believe that mid-class women, pregnant women, they do attend visit in private hospital. However, this make a big issue for obstetrician in a governmental hospital, because when the woman presented in labor, her file is completely empty. and she had no single episode in the governmental hospital. So she considered herself a booked patient, or like she did follow up. But in the hospital on ground, she did not have the obstetrician. They don't know anything about her on her background. And also hiding informations, and we've seen it commonly in obstetric, hiding number of cesarean section, hiding the critical situation like preeclampsia because of the fear of cesarean section, the fear of delivery. So these are, in my opinion, the major obstacles. Plus the burden on our shoulder as obstetrician. We may participated in this by indirect way, because we probably we didn't do our job in order to educate women from the start about from the preconception before pregnancy about the importance of antenatal care. It's not measuring fundal height. It's not listening to the fetal heart. It's categorization and anticipation and collecting threads and follow up. What was not obvious in one clinic might be full blown in the next clinic or the next visit.
Thank you, Dr. Faiza. I have my next question for Dr. Asia. The presentation highlights hemorrhage, eclampsia, sepsis, unsafe abortion, and obstructive labor as major causes of maternal mortality. Which of these is most preventable with current intervention, and which remain the most difficult to manage?
طيب صوتي مسموع؟
Yes.
ألو؟
صوتك مسموع. أيوة مسموع.
طيب إحنا would say all of them is preventable, to be honest, عشان أكون صريحة. طيب which one more, which one less, I cannot really specify. It depends, number one, on arrival time of the patient themselves. If the patient have accessibility to care early on, whatever the scenario mentioned or the cause, the patient likely is going to be salvaged. Now, if the patient arrived late, okay, despite late arrival, if we have an efficient system, as I mentioned in my presentation, where they have immediate recognition, immediate response, immediate resuscitation, immediate multidisciplinary team care decision, likely the patient would be salvaged, right? Of course, some patients, they arrived in a cardiac arrest situation. Some patients, they arrived dead body, to be honest. So it depends on the situation in arrival. However, I could say, having a very efficient system that cover all the needs for obstetric emergency life-threatening situation would reduce mortality significantly. Studies shown that the mortality on average go by 50% less when we have that efficient system. So I cannot really specify which one of them will be a leading cause of mortality more than the other, because it depends on the timing of patient's arrival or the accessibility of care, and it depends on the efficiency of the system itself.
Okay, thank you, Doctora. Okay, my next question is for Dr. Faiza. How can healthcare system shift from reactive model to a proactive one in maternal and newborn case?
طيب, proactive, it means we have to plan the condition from the start. Without having antenatal care, we cannot plan situation ahead of time. Plus, we have also to have a competent and integrated healthcare system that ensure early referral, early recognition, and as you mentioned in your presentation, and also Dr. Asya, she mentioned in her presentation, minutes matter in women's life. Single minute, it matter in case of hemorrhage, readiness of the hospital, readiness of the emergency department. Also, I wanted to highlight a very important point, putting patient in the center. If we engage, not patient, women, pregnant women, they are healthy women. If we engage them and we let them in the center of the care, and we allow them to elaborate and raise concern, each clinic, and build a good relationship with those women, I'm sure they will mention and they will help physician in early recognition. I will give you example, which is a common example. Women, they presented to the clinic and complaining of leg swelling, bilateral leg swelling. The first opinion or the first advice that this is normal. So this will gonna spread this. This pregnant woman will spread this message to her neighbors, to her friends, and this is not purely 100% normal, because we know that the between physiological changes and pathological changes in pregnancy is thread, fine thread or شعرة ما بين الطبيعي والغير طبيعي في البريجننت woman, fine thread. So we have to recognize when to highlight this issue as abnormal or normal. And even if I do believe that this is normal, I should give myself time in order to frequently assessing this normal and predict when this condition is going to be abnormal. I wish I did not deviate from the question and
لا ما شاء الله عليك يا دكتورة. لا يعطيك العافية دكتورة, الله يسعدك. طيب, my next question to دكتورة آسيا. How effective are obstetric rapid response team in improving survivor, and what are the main barriers to sustain them in all hospitals?
Okay. Now, rapid response team, one of the interventions was being practiced for the last maybe 20 years in the kingdom. But maybe in recent years, we heard about obstetric rapid response team, although, as Dr. Faiza mentioned, that it's pregnancy is a physiological changes. So the mother and the fetus should be healthy most of the time. So they should be have the support, to be honest, earlier than that. However, as per literature, it is very effective in reducing mortality, ranges between 30 to 40%, provided that it sustains its activity. Now, rapid response team need frequent team training, frequent simulation-based training in order to enhance its efficiency. Not only that, it needs frequent awareness and training of the inpatient staff and emergency room staff and anesthesia and OR staff in order to recognize an early sign of deterioration. So that would make the effectiveness and efficiency and the outcome of rapid response team is much better. The issue is when we say that we establish the system or awareness has been done, and then people, they start usually very enthusiastic early with any new service, and then with time things go lax. And here is come where we have to keep review and audit, and that's why we mentioned that surveillance is very important, where M&M has to be, mortality morbidity reporting should be very active in order to go into review, audit, and correct whatever correctable. And rapid response team is not only about availability of the team and then they call whenever needed. It's about whether really we are detecting an early awareness sign. Is it really reported? Is it really accessible? Even nursing? We know that RRT is about nursing, even are open to call. And the criteria go even down to whenever I feel not happy about the case, I can announce an RRT. As per guideline, even when the staff doesn't feel okay with the case, as simple as that, they can announce RRT. How flexible we are across different institutions, still we have no clue with that. Now, if it doesn't go through frequent training, audit, review, and checkup, definitely thing will go lax. And how we discover it? Simply when you look at the number of code blues versus the number of RRTs. It is expected that whenever there is an active RRT coverage, that the number of inpatients, CPR and code blue should be declined because cases expected that it will be detected before it go into a situation of cardiorespiratory arrest. Not only that, a review of those who are underwent CPR in the previous 24 hours before announcing the code blue in order to make sure that they have an early sign it was missed and the rapid response team was not called for. All these measures need to be taken. Now, when we look at different institutions, the audit is not the same, you know. But honestly, I think every case undergo cardiac arrest while hospitalized should have an audit review in the previous 24 hours to check whether there is a sign or symptom that indicate an announcement for rapid response team, and that was not happened because that will make the system more strong and more efficient. Again, in order for emergency obstetric care system to keep operating efficiently, generally, including the rapid response team, it need a lot of review and audit, and it need frequent simulation-based training and frequent awareness. Did I answer your question?
Yes, دكتورة الله يعطيك العافية. Okay, my next question to Dr. Faiza. How can we strengthen the antenatal care to cover not only physical health, but also mental health, psychological support, and education?
Very excellent question, صراحة. One of the SBAHI standard is psychosocial assessment of any patient in the ward or admitted patient or inpatient. But I always say, and when I mention this, I argue with my colleague about the importance of initiating psychosocial assessment from the start, because if we, again, if we believe in proactive medicine, we should do it this way. Despite that, the standard is written by us based on references, based on recommendations. The standard was talking about every inpatient, every admission in the hospital, including pregnant women. ولكن when it comes to pregnant women, I think it has to be the other way around. Why? Because again, if we are believing in proactive medicine, we should do it antenatally, not when the patient admitted. When the patient admitted, خلاص, يعني she started either to be with the 90% group of population who had normal delivery, whether vaginal or cesarean without any complication, or she might be with the 10% who developed complications. So my intervention, which is psychosocial assessment, is too late. She already finished her journey. She already passed through a lot during her pregnancy. He suffered a lot from anxiety, depression, overwhelmed by taking care of kids and by taking care of herself and the baby. So in my opinion, and I always argue with my colleague, that psychosocial assessment has to be done or need to be done antenatally with the first antenatal booking, and has to be done with the, in my opinion, again, humble opinion, every healthcare provider, including a social worker, midwife, a nurse, a physician, which is obstetrician, a primary healthcare physician, GPs, has to be done frequently all throughout the pregnancy. Otherwise, we will fail.
Okay, thank you, Doctora. طيب, my next question to Dr. Asia. The first case you presented, you showed a mother with eclampsia and severe ADRS requiring ECMO. What key lesson should a clinician take from this case about early recognition and escalation of care?
طيب, first an important thing, act fast, contact immediately. Don't assume that you know everything. The case was in Maternity and Child Hospital. That's a hospital separated from King Abdullah Medical City. Now, at that time, we were running intensive care coverage over there by consultants through the teleservices. Now, the primary physician or the consultant was the admitting consultant didn't have that barrier. Immediately, she picked the phone, she called us in order to intervene with a difficult case scenario. Didn't even wait for the tele-ICU round. And for that, when we hear patient scenario, we feel that we're dealing with very sick patient and with very difficult situation. Immediately, the team, they went and they attended. The call was just for intensivist physically to be with the case who is difficult to manage once we intubate, okay? So there was no border, okay? At that time, there was no privilege for the physician when they attend. There was no, there was no official consultation, to be honest. But the issue was that we have to act fast and immediate. So the team went there, intubated the case, start to manage the ventilator. It was very difficult to the extent we went into a very high level of support within maybe less than an hour. The barrier was not there to call for ECMO immediately, okay? And the ECMO was through the national team. Okay, we, as the King Abdullah Medical City, we have the ECMO-based service at our hospital. However, all the consultations from outside KMC, it goes through the national consultation. And what we did, we activated the national call, file filled up, immediately received. The team at the National ECMO team, they are very efficient, very active. They work on a patient immediately. So immediately the approval arrived and ECMO was done. The issue here that immediately engage the next person. Early communication, early recognition. The case was not dealt with as if we have an eclampsia and hypoxic patients and we'll put an oxygen and leave. No, the case was dealt with very high level of consideration where the primary team was didn't leave her at the bedside. And they contacted immediately a higher level of care, which is not available in the same hospital. They didn't fill the barrier, and we didn't fill the barrier too. We acted as one healthcare system. And here is, we set an example of a high level of care. Now we are in the process of creating a policy that it make the system run on the ground as a one service because it is needed. What we did, immediate recognition, immediate response. It's whatever mentioned in the literature about the emergency obstetric care, and then immediate intubation, immediate escalation into a high level of life support service, which is ECMO. Here is the discussion came. It was easy that we intubate, to put her on ventilator, we paralyze and we do everything, and then we leave it for the primary to pull the case to the OR. By the way, primary took the decision immediately to take the case for cesarean section with anesthesia. Both approved, they want to move the case. But we stand there and we said, no, hold for now. We have an ECMO support where it's likely going to salvage the mother and the baby. It's available. Why we have to push a patient with the oxygen saturation ranging between 80 to 85 to come out of the ICU? And we know by heart, once this case connected to into a portable ventilator, likely the patient will desaturate and she might arrest on the route. So why we have to take all that risk while we have another support? So here is where it comes a multidisciplinary care. So when we look at the case, how we manage and salvage and we succeed, we went through all the steps or the principles mentioned in the presentation that it's needed for highly effective emergency obstetric care system. We have recognition early, we have immediate response, we have a rapid response team on the ground and resuscitation. We have the multidisciplinary care where we agreed on the same scenario for the sake of both mother and the fetus. And then we have the high support level, and that's why we succeed.
Excellent, mashallah. And this is very excellent initiative, actually, and support a lot of organizations that don't have the ECMO service in their organization. Thank you, Doctora. My next question is to Doctora Faiza about the finding shows 30% of maternal death were among undocumented residents. How can healthcare system address inequity and ensure safe access for vulnerable population?
It's a very important step is to reassure those illegal women that they do have في يعني قرار المقام السامي إنه all pregnant women they will be treated equally regardless of the legal or illegal residence. So in order to achieve this, we have to reach to those community. I know it is challenging, but we start to in maternal mortality committee that is led by Dr. Basma. We start engaging community member from those from the community in order to spread the message that any pregnant woman is eligible to be treated in governmental hospital without fear of deportation. Without them having this knowing this message, يعني it will be challenging to avoid maternal mortality.
Thank you, Doctora. And this is really good support from our government. Allah يديمهم علينا إن شاء الله. والأمن والأمان إن شاء الله. Thank you, Doctora. For Doctora Asia, we have a question from the audience regarding the criteria for the obstetric rapid response team. If you have time to share it with us.
طيب طيب احنا will say for rapid response in general it wouldn't be a big difference from obstetric, where in obstetric we will consider this just the fetal part of it, absence of fetal movement, absence of fetal sound during examination, probably that would be added. Other than that, I want it to go simple, because memorizing and all it's a burden on everyone. From intensive care point of view, any patient who has hemodynamic changes, mean hypotension or hypertension, patients who has seizure, patients who has deterioration in the conscious level as simple, patients whose oxygen requirement increased, okay, a patient who has a fever, a patient who is tachycardiac or bradycardiac, a patient who is having, would say, change in oxygen saturation, a patient who's having bleeding. Nobody will measure bleeding how much, to be honest. You can look at the amount of bleeding by yourself. But generally speaking, if you feel not comfortable with the patient situation, simply you are allowed to call for rapid response team. Similarly, in obstetric rapid response, the situation should be equally the same, because I don't think a nurse or any physician would feel critical with a patient who is perfectly doing well. I mean, nobody will call rapid response because they feel not comfortable with the case or not happy with the patient, while the patient is eating, drinking, walking, talking, has no issues, no complaint. So here's where it comes. A rapid response should be flexible, available to that extent, because the aim from having a rapid response service within hospital institutions is to prevent CPR, to prevent deterioration, to prevent admission to the ICU, early detection of clinical deterioration with early management and resuscitation. And we know in all spectrum of medicine, early intervention would come up with an excellent outcome. Delayed intervention, delay accessibility to care is always associated with poor outcome. So simple, straightforward, simply, if you look at the vital sign per se, and you see a derangement or a conscious level changes or a change in oxygen requirement or bleeding or pain, by the way, a pain that is not controlled by simple analgesic, or you are not happy with the patient in front of you, even if you don't know what's going on, but you feel that that patient is not okay, you're allowed to announce for a rapid response team and you call for help. And the rapid response, by the way, it is expected from the rapid response team to have a high level of communication, cooperation, mentoring for care. The team has to be trained very well at that level, because they are the one who is expected to be called for a patient's care concern anytime. So blaming, fighting, rejecting, criticizing is not acceptable. This is very important. It should be part of the training for rapid response team members.
الله يعطيك العافية. Thank you, Doctora. We have here a question for all of us from one of the audience, to Doctora Asia and Doctora Faiza and myself. What is your practice targeting inpatient safety regarding newborn and children within the private sector? Are there any different between the private and public sector?
ما أعرف, shall I start?
Yes, دكتورة. الله يعطيك العافية.
Now, when we talk about a healthcare system, we're talking about healthcare system across the whole country. طيب. At a smaller level, would say across the whole cluster. Now, a strong healthcare system should have a strong collaboration and cooperation and communication, and should have a unified level of standard of care. Okay, whether when we talk about system, we're talking about governmental, private, everything. طيب. So it is expected that there shouldn't be a variations. Now, variations come because of variation in the practice, variation in the standards, and we know that still there is some gaps that need to be closed within the healthcare system. However, it's not expected that there is a variations as much as the population will have, I mean, selections for one side and the other. From healthcare point of view, all of them should be equal.
I agree with you. Yeah, يعطيك العافية. Yeah, I agree also with you. whether you are private hospital, government hospital, or tertiary hospital, safety should be implemented equally, same for all the healthcare sector. There is no different from private or public health or even tertiary hospital. All the requirements should be implemented to prevent harm from reaching patient. We are here to protect our patient and keep them safe with no harm. Okay. Do you have, Doctora, any additional comment?
I agree with you. I have no further comment.
Allah يعطيك العافية دكتورة. There is another question here from Ethiopia. There is a problem with the availability identification band. Hospitals don't have access to this band, and because of this, we cannot implement this important identification system. Awareness has been created, but barcoding hasn't yet been introduced. How to help this? So this question is to me regarding identification. It's very important. It's one of the essential of the international patient safety goal. Having a barcode or other devices that help us to prevent error from happening, it's a luxury. Yes, I know some organization or some countries, they don't have access to it, but the essential or the primary thing is to have identification where you have at least patient full name and medical record. And usually we for some organization, they do it as a handwriting, and we have to do an independent double check. You don't have to have a system to help you to do a correct identification. Other barriers that help us to prevent error from mistake or error from happening, that if they are adult patient or a pediatric who can speak for themselves, you ask them for their information. You don't offer them the information. So this is one of the safeguard to prevent error from happening. If you have children below this age, usually you ask the guardian to give you the information. Okay. I think this is all question from the audience.
كان في سؤال عن الامنيوتيك فلويد امبوليزم.
Yes. Try to find it. Here. So there's one question also about the prevention of maternal mortality. There are unpreventable cases even with the best healthcare system, like amniotic fluid embolism. We must put that in mind. So,
طيب
دكتورة آسيا. Yes.
تسمح دكتورة آسيا إنه أنا أبدأ وبعدين هي تكمل. If you allow me, دكتورة آسيا. Yes, amniotic fluid embolism is acute condition. However, it's rare. It's not quite rare, but when we look to statistics, number one in our kingdom is hypertensive disorder, then postpartum hemorrhage, then sepsis, then other reason like cardiac related issues, VTE, and amniotic fluid embolism. I would like to listen from Dr. Asia because we know that amniotic fluid embolism is acute situation where we have to act. So my question, based on the audience question, do we have time in such cases for ECMO?
But we know that amniotic fluid is very dramatic, has a dramatic course. Usually it's very fast and all. Now, with the aim of having the system is not to look at whether this patient is going to make it or wait for me or not. What we're saying, always act, okay? Resuscitate. Don't think about the end result, because if we look at this patient is gonna die. Example I presented, that patient was having a saturation ranging between 80 to 85 for at least 3-4 hours, okay? It's easy that we give up on the case and we say already she's brain anoxic, take the case to the OR, do the section, get the baby, let her die, no problem. But we thought that if we get the ECMO in, the patient is young, her hemodynamic was okay, the brain was perfused very well. We know that with pregnancy, oxygen dissociation curve go to the right, so tissue oxygenation likely is better. And we look for the best scenario. We supported her, we get the ECMO in, and eventually there was a dramatic response from the mother, was not expected, that she was coming out of ECMO in 5 days, was extubated in the 6th day, and the 7th day she went to the floor. Sometime it needed from us to fight for the patient. I'm not saying you receive a dead body already and you have to do for him resuscitation. However, a witness arrest, it deserves to do all the effort in order to support the patient. Now, if you have a maternal cardiac arrest, what you will do? Immediately, one of the interventions that if the resource available, get ECPR. ECMO CPR was included even in obstetric cardiac arrests. Now, whether the patient is going to come up with a good outcome or not, if we go with our system very well, where the setup has to be there, the act is very fast and the response very fast and the intervention are very fast, we may learn in the future things is different. We cannot assume that, okay, there is no place for amniotic fluid embolism, okay? Now, how we knew about amniotic fluid embolism? Because there is a case that survived till we diagnose, at least. Otherwise, we wouldn't diagnosing amniotic fluid embolism except post-mortem. Now, there is one research where they did the systematic review of the case reports and the reported cases out of the whole studies done on ECMO in pregnancy. So they isolated just the amniotic embolism cases. And there was a survival among them. There was a salvage of at least 40%, which is, I think it's not bad. It's not bad. So my message is, whenever you come across a young pregnant patient, I think we have to do all the effort to salvage her, because young population, no matter they are very sick, they survive, they make it. And when they make it, they do very well. We come across frequently a very sick pregnant ladies in the ICU where they go septic shock, multi-organ failure. But because we act very early among them, they make it. They stay in the ICU 1 month, probably 6 weeks, 1.5 months, but they come out of it very nicely. They need a long-term rehab, yes, but they survived. So the key message here that we need to have an efficient and very strong integrated system. And we need to be ready with all the life support available facilities. I think having a cluster here and there, having the ECMO national team is a strong support to do that. Still, we will lose some of the patients, yes, but at least the mortality will go much less. The studies is saying on average a reduction of 50% in the mortality. And in rural areas, when they manage to implement an emergency obstetric care system, they reduce the mortality by 70%, even in rural areas. So I don't want to keep in mind the barriers before you act and do. If we act and do, we may see a different outcome.
Thank you, Dr. يعطيك العافية. We have just to comment here. Excellent case discussed, but being a pediatrician, it's very disappointing situation regarding breastfeeding. I have heard so much about breastfeeding, attending seminar in KSA, but on ground the situation is worse. Another comment here, an excellent class. During my shift also, I announced the RRT. That time really I didn't know about the detail because I was new. Now I understand completely what meant by the RRT and when we have to announce. Thank you. This is the comment here, and now we came at the end of the session. Thank you all for attending this webinar, and inshallah there will be a more announced webinars in the future. Thank you all. يعطيكم العافية.
Thank you. شكرا هبة.
شكرا.
Thank you all the team.
الله يعطيكم العافية.
العافية.
شكرا هبة ونجلة.
Thank you all the team.
شكرا دكتورة آسيا.
شكرا دكتورة. يعطيك العافية.
Thank you.